So let me do just a couple of things to set context here about lean thinking for healthcare. It has been a long march. I have been observing it for a very long time, mostly with a great deal of frustration. I'll have an e-letter tomorrow that'll come out just about this time tomorrow morning. Those of you who get my e-letters, I will just go through the history, very briefly, of trying to apply lean, born in the factory, born in the snowblower factory that John Toussaint tells you about in his book, trying to make a translation into touching human lives. This was not an easy thing, either intellectually or practically, and so it's not surprising that it's taken a lot of time. It's also not surprising that a lot of the experiments have failed. And by the way, we should always just say, we're doing experiments, some work, some don't. That's how we learn. In your discipline, more than anywhere, science must be respected. It's all about PDSA, Plan, Do, Study, Act. Recently, though, I think we are really at the tipping point. And we're at the tipping point because of the crisis, that we've now tried all the easy things that don't work and in healthcare, so now it's trying to try some hard things, some of which do work, and which I think those in this room are uniquely able to talk about. So it calls for new initiatives, new transformation methods. There are two pieces to this puzzle. First is the external environment, which is to say the way society thinks about rewarding or punishing those who provide health care, how society thinks about the visibility of outcomes, whether we're really going to know how people are performing. So that's outside, if you will, the black box of what goes on in healthcare. And then there's the internal environment, which is the black box. I don't mean that as good or bad. It's just, for a lot of folks, opaque about what's really going on inside the healthcare delivery process. And so we have to fit those together, that you can't fix what's inside the box if the incentives, rewards, punishments that are being offered outside the box are completely, totally opposite to what you need. And by the way, that has largely been the case in this country and in a lot of the other countries present. So therefore, we need to fix what's outside. You need to fix what's inside. And then together, you'll have something that will actually work. However, as we do that, just a word of caution. I know a lot of heroic friends in the lean movement, and I love all of them. But we mustn't overpromise what can be done just inside the box. I spent many years trying to save Detroit. And one of the ironies was that the day General Motors collapsed, it was a better company than it had ever been. Had practically matched the best companies in productivity, in its new products and quality, and its new product development process, and the company failed. And the reason was that the external context, in their case, how management and labor and government work together, could not support the good things that were happening inside the box on the shop floor in the design operation. And so the whole thing went bust. So therefore, let us not be overly heroic. We cannot fix healthcare just from the inside. We have to fix the context as well. And there's some good folks working on that. By the way, my friend, person I truly admire, Don Berwick, has been nominated to be head of Medicare and Medicaid. Let us all hope that this miraculous event happens. Don is the man who knows what to do with our help, could change the context in which you all work. But this is not a done deal, and this has to be the toughest job on the planet. $850 billion of check writing authority, and every single person has got some interest in this, and they're all opposed. You know, the hospitals and the insurers and everybody else. So let us all wish Don the best and give him as much help as we can. So therefore, we're going to start this morning by trying to set the context, the environment. And John Toussaint is going to do that for us. Now, you have on your table a book. That's a wonderful thing that Dr. John Toussaint and Roger Gerard, where's Roger? Raise your hand, man. Okay, right over here. PhD, have written, which is the case study of Theta Care with the principles of lean healthcare at the front and the action plan for what they've learned about what you need to do to transform healthcare organizations at the end. So there's your book. Urge you to read it on the way home. I mean this as a compliment, John and Roger. This is a fantastic airplane book. Once you start this thing, you can't put it down. And it's about your life. This will be all about you. Just change the names, and it's about you. Same situation, same problem, same agony, some ecstasy. So therefore, that is for you. But that's not what John's going to talk about. He is going to set the context for where we stand and what we need to do outside the box so that we can make necessary change happen. Now, let me just say one more word for John. Come up. I can tell when I meet somebody whether they are going to make something happen. And when I met John the first time, which is quite a while ago now, I said, I don't know whether he's going to win or lose, but this guy's going to play the game to the end. He's not going to take prisoners. He's going to make something happen. And so he was a doc, still is a doc, was a medical director, hospital, CEO of a medical system, and now the founder of the Theta Care Center for Healthcare Value, which is a nonprofit which Theta Care has been generous enough as an organization to fund. That's not for their narrow benefit, it's for the good of the whole country, indeed of the whole world. So John has now taken on the big task, having done a lot of things for Theta Care to the proof of concept, is now going forth to try to create the environment that will make it possible for all of you to have an easier time doing the right thing. So, I've said enough, not even supposed to be here. John, you are supposed to be here. Tell us about the context.
Well, thank you very much, Jim, for that kind introduction. And, you know, we do have a real opportunity, and it's pretty exciting. Last night, there was a real buzz in the room, and I don't think it was just the wine, but there was a buzz in the room, and I think that Jim's right. If there's anybody that's actually going to be able to solve this problem, and I'm going to describe what this problem is, it's the people in this room this morning. So we're excited that you're here. This is the first annual Lean Healthcare Transformation Summit, and we expect that there will be many more to come, and that some of you in the audience today will actually be presenting to the group next year. So we're excited to have you, and my job is to set the context. You know, we all sort of know what the context is, I think. Basically, this thing is a mess. And the question is, you know, in a good A3 thinking mindset, are we solving for the right problem? Have we actually solved for the right problem over the last few months? And that's certainly the question I've been asking myself as I've listened and as I've testified and as I've done everything else that one could do in Washington, is are we solving for the right problem? So let's start by trying to understand what that problem really is. You know, we all know that the U.S. is almost twice as expensive as every other country. But did you know that the rate of increase is dramatic, exponential? So this is the rate of increase of healthcare expenditure over the last 20-some years. And you can see that actually in the UK, the rate of increase is a little higher than the US. And what they're doing in Japan is probably what we need to do, right? I don't know what they're doing. But the point is, the problem is the rate of increase in expenditures, which is what this slide shows. So, you know, before we can do countermeasures, we got to understand the problem, right? So the question is, did our legislators understand this problem, and did they solve for that, for the right problem? So what is the reason for some of this stuff? Well, here's part of it, is that we're all, at least some of us, are getting old, and that many of us have chronic conditions. In fact, 133 million Americans have a chronic condition, which account for 81% of the hospitalizations, 91% of prescriptions, 76% of physician visits. It accounts for 75% of the nation's $2 trillion plus in medical costs. And these are the things that are causing it. Diabetes, and of course our epidemic of obesity in the U.S. is the major reason for diabetes, as well as heart disease, and on and on and on. So we've got this problem. It's called the rate of increase of cost is on an exponential growth curve, and we have an aging population that is getting sicker and sicker. So this is what they did in Washington. They enacted these two bills, 2,400 pages long, the Patient Protection and Affordable Care Act and the Health Care and Education Affordability Reconciliation Act. So this was what all the angst was about for many months. So what is the impact? I'm not going to talk about the insurance side today. I'm going to talk about the delivery side, but there's one slide here on insurance. And by the way, I have an appendix of slides on both the insurance reform and the delivery reform. So if you really want to dig into the details of this, at the end of my presentation, you can, when you go online to get these presentations, I have about 20 slides that very deeply describe the healthcare legislation, but we don't have time to go through the details today. So by 2020, we're going to have 11 million more Medicaid members. We're going to have 24 million people in these what are called health exchanges. And we're going to have still 22 million uninsured people, most of whom are unauthorized immigrants. So that's the basic insurance piece to this thing. This is how we're going to pay for it. I want you to keep in mind, did we solve for the right problem here, okay? Remember what I said. I mean, it's the exponential increase in cost that's the problem. So what did we do? What did our legislators do? So they added a $938 billion entitlement. And how they're going to pay for that is we're going to cut payments, right? So we're going to cut payments to Medicare and Medicaid. Those are already our best payers, right? And now we're going to cut those payments. So we're going to have market-based adjustments based on productivity. So what the government is suggesting is that every hospital can become more productive, and if they do, they don't need all this money that we're already not getting paid. All right, so we have market-based adjustments, restructuring of payments to Medicare Advantage, so they're going to take it away from the health plans that do Medicare. We're going to reduce the disproportionate share payments, and we're going to have some other cuts. And then we're going to, on the right-hand side, revenue, we're going to increase fees to the pharmaceutical and medical device industry. Of course, you know where that's going to end up, right back on our shoulders paying for it. We're going to have higher taxes. We're going to have a Cadillac tax, which means if you have insurance that is basically first dollar coverage, you're going to pay a tax for that. And then there's going to be penalty payments, and you know, some of the tanning booths are going to go out of business. So we've got cuts, and then we've got taxes, and that's how we're going to pay for this. These are where the goals of the delivery reform, okay? So we're going to try to control spending, reduce the focus on quantity, whatever that means, and then improve the quality of care. So when we look at the reform components, these are the core components. We're going to create a new Center for Medicaid and Medicare Innovation. I met Tony Rogers, who's the director of this new innovation center. They're going to be going out and looking for some of you to actually engage with them to become innovation centers. Not quite sure what that means yet, but that's what they're going to do. We're going to have an independent payment advisory board. So MedPAC, which is really sort of a political organization, is going to be replaced. Actually, they're not